with
Yes.
G9 webinar.
Yes, indeed, indeed.
Yes.
Very much so. I'm just missing your red chair.
How is the situation there, Suman?
The situation actually is, we believe it's under slightly better control than other places in the US. We started operating with elective surgeries and full-on clinics this week. So it's been a busy week, obviously, but, we, as with everything else, we must learn to coexist with this virus, this disease. It's not going away.
Yes.
But the wonderful thing is that here in the US, everyone is now starting to adopt our greeting.
Absolutely.
So we are live now. I'll just start the session. Good morning everyone, and good evening to everyone seeing from the United States. We welcome you all to Ortho TV Online on this webinar on anatomic reverse total shoulder arthroplasty and reverse total shoulder arthroplasty. So over to Dr. Karthik Selvaraj to continue with the proceedings.
I invite Dr. David Rajan to introduce the speakers and start the meeting.
Good morning. This is Dr. David Rajan. With me is Raghuveer Reddy from Hyderabad and Gopal Krishnan, father of Sumant Samir. He may not be very active. He is one of our mentors and friend of Indian Arthroscopy Society. And welcome to this webinar, Reverse Total Shoulder Arthroplasty in 2020, a real-time discussion organized by Tamil Nadu chapter of SESI and Coimbatore Orthopedic Society. We welcome and we are very thankful to Sumant Krishnan and his colleague Eddie Lowe. They are from Dallas. They are from shoulder department, shoulder surgery from Baylor University. Welcome. And they both are, Sumant is not new to us. We have seen him operate, and he's very gifted in the sense he can think. He can think as fast as he can operate. And Eddie, welcome. And with us is my good friend Sanjay Desai, past president of Shoulder Society of India, and Ram Chidambaram, present Shoulder Society of India president. And of course, Karthik, you all know, his hard work. This webinar has been possible. So we will have 3 talks first, and within half an hour we'll get over, followed by discussions. There will be 3 cases presented by our faculty, and by 1 hour, Sumant and Eddie will be leaving, and we can continue the discussions as we like. So can I call upon Sumant for the first talk on anatomic reverse total shoulder arthroplasty? Is this the current state of the art? Sumant.
Thank you so much, David. It's truly an honor and a privilege to join, all of my colleagues in my homeland. As all of you know, my father has been a mentor not only to everyone who's probably watching here, but to me as well. And I congratulate the Shoulder and Elbow Society of India, to Ram, to David, to Sanjay, Karthik, all of this fantastic scientific knowledge. I had the privilege of being there last year, obviously in person, and now we can do this with technology. So without further ado, we wanted to introduce today a concept that perhaps seems heretical, to talk about anatomic total shoulder arthroplasty and reverse total shoulder arthroplasty, but in the same context. And so this is an evolution of something that we began here in Dallas, nearly 20 years ago. And we really believe that the facts will bear out what we're going to speak about. My disclosures are no different than anything that you can find online at the American Academy of Orthopedic Surgeons. So without further ado, my mentor, Richard Hawkins, once said that if it's not published in the peer-reviewed literature, it's just opinion, but the opinion may not be wrong, because the opinion must be substantiated by fact. Well, fact number 1, glenoid deformity is most often a multiplanar pathology. When we look at the glenoid, we see that there's a radius of curvature at the superior part of the glenoid that is different from the radius at the inferior part of the glenoid. Therefore, when we see erosive patterns in the glenoid related to arthritis, whatever the cause of the arthritis, the erosion can occur in the medialization plane, XY plane, in the inclination plane, the XZ plane, or in the retroversion plane, in the XY plane. What that means is that there's a predominant plane of deformity that occurs with all arthritis, whether it's retroversion, medialization, or inclination, but there is always a secondary component of that deformity as well, simply because the glenoid is not a flat surface. So retroversion is often accompanied by either medialization or inclination changes. Medialization is often accompanied by inclination or retroversion changes, or all three. So if this is the case, that it's a multiplanar pathology, how do we just address this with one type of a surface component? Fact number 2, anatomic humeral reconstruction may not truly function anatomically in the diseased shoulder. All of the implants that are available in your country, in my country, worldwide, were designed based on normal anatomy. Well, normal anatomy predicates that the rotator cuff is normal. In the early 1970s, when Dr. Neer first described doing total shoulder arthroplasty, he stated that 98% of the time when patients had an osteoarthritic shoulder, they had an intact rotator cuff. Well, I'll submit to you that Dr. Neer was likely right about the cuff being intact, meaning a tendon coming to the bone. But the cuff muscle is not normal. We know that if you take everyone over the age of 50, 25% of people have functional deficits of the rotator cuff and even tears without knowing it. How is it the case that we have this arthritic shoulder, as you see here, with a predominant medialization and slight inclination change, but yet there's fat, as you see in the bottom left of the screen, within the supraspinatus and the infraspinatus? If that's the case, and there's an adaptive mechanism of the cuff to aging and arthritis, then by definition, if we take that articular surface and then recreate what was the articular surface of a normal rotator cuff shoulder, it will likely not function. When a patient is 38 years old, 48 years old, 58 years old, the posture is different from when a patient is 18 years old and 20 years old. As the scapula starts to tilt, as the cervical-thoracic junction starts to lose hydration, as we start to develop ptosis, there's an adaptive mechanism of the rotator cuff that necessarily means it doesn't function in the same way. Therefore, if we try to replace the joint and the articular surface in the way that was designed when we were 18 years of age, we may not be doing the cuff a correct service. Hence, fact number 3, anatomic historical total shoulder arthroplasty is not as durable as originally reported. In the series from the Mayo Clinic and from Columbia, New York City in the late 1980s, early 1990s, the success rate, the longevity of a glenoid was reported to be for polyethylene keel glenoid over 95%. Well, over the last 10 years, we've seen from the peer-reviewed literature that actually that's probably not true, and the failure rate of anatomic polyethylene glenoids exceeds 69% at 5 years. And why does this happen? Well, it depends on how we define failure. If we define failure as progression to revision surgery, that's different. But if we define failure as a shift in the component such that the component is no longer exactly in the position that we implant, then this is what our eyes do not show us. This is my good friend, Professor Roger Emery from the Imperial College of London. He was the president of the European Shoulder and Elbow Surgeons Society 4 years ago. And he demonstrated very clearly how this happens. He cyclically loaded polyethylene glenoid components that were cemented and did this over the course of time to simulate what happens over 1 year. And what happens at the superior part of a glenoid component is compression. At the inferior part is distraction. What this means is that location of failure is only seen around the microscope. It's a deep bonding of the cement implant interface because of failure due to compression at the upper part of the glenoid rim and failure due to distraction at the lower part of the glenoid rim, therefore tilting the glenoid component. Ergo, the glenoid that you implant is not actually the same at 1 year. So consequently, perhaps we need to reconsider completely this idea of putting polyethylene on the glenoid. It's not done in the hip anymore. It's not done in the knee anymore. It's not done in any other joint. Fact number 4, reverse total shoulder arthroplasty is no longer the same procedure. This is Professor Paul Gramont. I had the pleasure of meeting him before he had his stroke. And we understand the original Gramont philosophy was to medialize the center of rotation so that we effectively distalize the deltoid, recruit the deltoid to function in a cuff deficient shoulder. Well, our president-elect for the American Shoulder and Elbow Surgeon Society, Professor Mark Frankel, demonstrated that as we lateralize that glenoid component and restore a more native anatomic center of rotation with a convex semi-constrained implant, we have improved function in both rotation and recruitment of deltoid fibers. The reproducible midterm outcomes of these modern day reverse arthroplasties are very durable. My good friend John Sperling at the Mayo Clinic has demonstrated at the 2 to 5 year follow-up, Mark Frankel, greater than 90% survival. And while 5 years is still short term for arthroplasty of any joint, it's very encouraging. The Mayo Clinic demonstrated that primary reverse shoulder arthroplasty with contemporary implants has a very low failure rate, less than 1%. And the biggest worry, the glenoid base plate, has an extremely low failure rate. And we also reported this 2 years ago at the American Shoulder and Elbow Surgeon Society in nearly 900 of our own patients with a contemporary implant and a very low base plate failure. So what does this mean in 2020? Well, this is the latest data from the 2019 AAOS Shoulder and Elbow Registry. So this is the American Academy of Orthopedic Surgeons, and this is the shoulder and elbow registry of all shoulder arthroplasty procedures performed in the United States for the last 5 years. Look at this, 60% were performed with a reverse inclination. This is our own Baylor Shoulder Service over the last 16 years, and as you can see, the growth of reverse arthroplasty is almost linear, paralleling what we see around the rest of the country. This is an interesting slide from the AAOS Shoulder and Elbow Registry demonstrating that the crossing point between reverse arthroplasty and perhaps consideration of some type of a historical anatomic total shoulder is actually much different. It's about the time that we expect the rotator cuff to fail, between 50 and 60 years of age. Similarly for us, when we look at all of our patients over a 15-year time frame, more than 2,400 patients who underwent a reverse arthroplasty, the majority, again, start at the age of 50. So this is not in the peer-reviewed literature, but this is just opinion. However, for patients who are under the age of 50, who have a concentric center of rotation, an A1 glenoid, E0 glenoid, E1 glenoid, perhaps I may consider putting polyethylene on the glenoid, but more than likely, I will probably move to just a simple hemiarthroplasty. For patients who have a non-concentric center of rotation, in my hands, there's no question a reverse total shoulder arthroplasty done anatomically is the best option. For patients over the age of 50 who have an almost certain type of cuff disease, even though we may not actually see this, for me, this is only going to be a hemiarthroplasty if they're concentric, and if they're non-concentric or have any erosive pattern, I'm moving to a reverse arthroplasty. And definitely for the patients over the age of 60. So what is the future? Well, currently we have these preoperative planning softwares that allow evaluation of the existing implant designs. What I mean by that is that you can take all of the companies that are now in the industry with their implants and use their software to evaluate their implant to determine how to implant this. But that's not how the implant is designed. The implant was actually designed for a normal shoulder. So we're taking an arthritic shoulder, using a design that was computer generated based on normal anatomy and trying to make sense of this with an implant. And perhaps this is the future, an artificially intelligent driven reconstruction that is actually based on the diseased anatomy, not the normal anatomy. Taking the diseased cadaveric specimens, the diseased shoulders, and working backwards to create an implant that's patient specific for that patient, understanding that we're trying to repair not only the joint itself, but the rotator cuff. So the future, I submit to you, stay tuned. It's an anatomic reverse total shoulder arthroplasty. Thank you.
Excellent, excellent, Sumant. Do you want Eddie to do the talk, or do you want to continue with the second talk?
No, absolutely. I think I would like to take the honor of introducing my colleague at the Shoulder Center of Dallas, David gave him a nice introduction. Dr. Eddie Lowe, he actually grew his roots with Dr. Stephen Snyder. Of course, we all know Dr. Snyder, one of the world's most famous arthroscopic shoulder surgeons. And then we had the pleasure of having Eddie with us in Dallas for almost 10 years ago. He went back to San Francisco and created one of the largest shoulder practices in San Francisco. And we, after many years of recruitment, were finally able to bring him back home to us here in Dallas. So without further ado, Eddie is going to present to you our concept of how to perform this type of an arthroplasty.
All right. Again, thanks, Dr. Rajan and the Shoulder Elbow Society of India for inviting me here. It is truly a great honor for me. And everything I present here is really taught to me by my good friend and mentor, Dr. Krishnan. And then let's talk about the anatomic reverse shoulder. I do not have any other disclosures. So when we talk about the principle of anatomic reverse shoulder arthroplasty, it's really two key aspects. The first aspect is the restoration of the native joint line, the sweet spot where the glenohumeral joint lives on. And we do this through a combination of glenoid lateralization and humeral medialization. The second point is to really preserve the soft tissue structures. So we try to repair the rotator cuff whenever possible. And we do want to preserve the deltoid function as it is the main motor muscle to power the prosthesis. At Baylor, all of these procedures are of the primary reverse shoulder arthroplasty are performed through the anterior superior approach. The advantages are that it minimizes the subscapularis tissue trauma. It allows easier access to the posterior rotator cuff and lower the risk of postoperative instability. The disadvantage is it does involve a deltoid takedown and repair is necessary, and that it's a limited surgical incision by the path of the axillary nerve. As we talk about the surgical video in a few minutes here, I really want you to keep in mind a couple key surgical points. On the glenoid side, we do a patient-specific bone grafting technique. As Dr. Krishnan had previously said, the wear on the glenoid is a three-dimensional pattern. So we need to look at the preoperative 3D CT scan and measure them. And once we decide that we need a glenoid bone graft, we harvest the autograft from the humeral side and we precisely reshape the graft for the reconstruction. On the humeral side, we perform an inlaid prosthesis to effectively medialize the humeral component. Then we do a follow-up soft tissue repair for the rotator cuff and reattach the deltoid. This is a right shoulder patient with osteoarthritis and intact rotator cuff. The incision is made over the anterior edge of the clavicle down to the anterior corner of the acromion to expose the underlying deltoid. The key is to release the anterior deltoid from the distal clavicle, anterior acromion, and down the anterior deltoid raphe. This extends about 2 centimeters lateral to the acromion. Then you can access the anterior superior portion of the rotator cuff and the rotator interval. The superior edge of the subscap is detached here and tagged. You only need to detach the tendinous portion of the subscapularis and preserve the muscular portion in the anatomic insertion. We then place this blunt retractor into the glenohumeral joint and use a cob retractor to pull back the pectoralis muscle. We can also adduct and flex the arm and pull down part of the subscapularis to reach the capsular tendinous junction and release along the inferior humeral head. Then with this large Hohmann retractor, we can expose the entire humerus. We remove the osteophytes and visualize the neck junction. We place this K-wire and utilize a circular saw to harvest a cylindrical shaped humeral bone graft. As you can see, this is a pretty thick graft, about 2-3 centimeters. We then complete the neck cut with an oscillating saw. Then we make sure we can expose all the way around the inferior humeral neck, past the 6 o'clock position. We could remove additional osteophyte if we need. In the back table, we use this oscillating saw to prepare the subchondral portion of this humeral bone. And this is the strongest portion of the bone. We use a cutting jig to precisely cut a wedge bone graft based on our preoperative measurements. And this is now a beautiful wedge glenoid graft. We place this on the base plate and we're ready to implant. Now we come back to expose the glenoid. Although this is the superior approach, the visualization of the glenoid is no different than the deltopectoral approach. We mark the center point of the glenoid with a cautery, and we can mark the posterior superior neoglenoid, the point of the wear. We then place these generic retractors anterior, posterior, and inferiorly. These are low profile, non-bulky retractors, so we could really visualize the glenoid here. The key is this anterior inferior portion. We want to keep this base plate low enough and just slightly overhang the inferior side to minimize notching. We use a threaded central screw style of the base plate because we want to engage the scapular neck with this central screw. Then we could compress this base plate down the glenoid bowl and dial the graft to match the area of the glenoid wear. In this specific style of base plate, there are 4 variable angle locking screws. The central screw captures the glenoid neck. The superior screw here is aimed at the base of the coracoid. The anterior screw is aimed at the scapular spine. The inferior screw is parallel to the central screw, and the posterior screw is engaging the lateral pillar. At this step, we could check around the base plate to make sure there's no soft tissue that's impinging and potentially preventing the seating of the glenosphere. This specific glenosphere has an impacted Morse taper for fixation, and then a central screw to engage the base plate itself. In our technique of anatomic reverse shoulder arthroplasty, we always start with the glenoid side first and then the humeral side. This allows for any adjustment to be done on the humeral side for bony or soft tissue deficiencies. We use this rod reamer to inset and inlay the prosthesis. This effectively medializes the humerus. Then the glenoid component is a lateralized implant. So like Dr. Krishnan said, this is a biomechanically advantageous configuration for maximizing deltoid function and restoration of the joint line. We're utilizing a short curved humeral stem here. We progressively broach until we have an uncemented, primarily stable humeral implant. It is set at the native humeral version. And the medullary canal is about 1 centimeter posterior to the bicipital groove. Per Dr. Neer, if the arm is in the neutral position at the side of the body, the humerus should point toward the glenoid about 20 degrees retroverted relative to the transcondylar axis. We place this inlay tray to match the osteotomy surface, and then place these transosseous non-absorbable sutures for the subsequent cuff repair to come. We can also utilize these sutures to repair the biceps as we need to. Then we impact this humeral component down to the anatomic neck along the osteotomy height. As you can see, this humeral tray now sits at the level of the tuberosity, if not a little bit below. We impact our final implant here and then insert this 6 millimeter polyethylene component. Now we're pretty much done with the prosthetic implantation. I hope you're ready for this. It is finished, number 1. Now you can see the glenohumeral reduction is actually pretty gentle. It's a 2-finger technique. And now you can see the good smooth coaptation of the glenohumeral joint. As you can see, the implantation process is no different than if one would operate through the deltopectoral approach. The difference is really in the repair of the rotator cuff and deltoid. This subscapularis tendon is only released in the superior part. We now mobilize it and repair it back to the posterior cuff with these non-absorbable sutures. We attach the anterior subscap back to the posterior superior rotator cuff, and then the posterior superior rotator cuff back to the anterior rotator cuff. This really restores the anatomy as it was. Voila. Then we release the deltoid from the subcutaneous tissue. It's a fasciocutaneous release. This takes the tension off the deltoid. We then place a running vicro suture as a riptop stitch about 1 centimeter from the edge of the deltoid. Then we place 6 cerclogene and transosseous sutures around the clavicle and through the acromion. Once this deltoid is repaired, the deltoid has both a transosseous and transmuscular repair, which allows for immediate rehabilitation. This is a consistent and reliable technique to restore the glenohumeral joint line and preserve the natural soft tissue anatomy of the proximal humerus. And this can be done through a pretty elegant incision. Thank you.
Excellent talk and very elegant demonstration of the procedure. So Sumant, and you do the whole surgery in 10 minutes, I suppose. So that's great. So
12 minutes. 12 minutes.
Okay. All right. So Sumant can continue with the next talk.
So we'll, that's absolutely a wonderful demonstration by Eddie. He's an incredibly skilled surgeon, but I think just to highlight one of the important points that Eddie was making, please try this in your own hands, because if you follow these technical details, it really becomes a far less daunting task to implant a shoulder. And that's one of the things that I first learned from Professor Paul Gramont and Professor Daniel Mollet in Nancy, France, that the anterior superior approach is nothing to be afraid of, just like the deltopectoral approach is not to be afraid of. It's just to be understood. So in the interest of time, let's go ahead and move to our next talk, which is really the most common complication that occurs as a surgeon will face after reverse total shoulder arthroplasty, and that's the unstable reverse total shoulder arthroplasty, the absolutely maddening complication. And hopefully I'm going to share with you some ways to learn from my own mistakes. Once more, my disclosures are no different. Instability after reverse shoulder arthroplasty, the incidence is up to 31% of cases. We know that the infection rate for modern primary reverse shoulder arthroplasty is no different from what it is for anatomic total shoulder arthroplasty. We also know that the incidence of wound complications and such is probably not so much of an issue. So instability is really the bugaboo, if you will, that surgeons are going to face after performing this implant. It generally occurs less than 3 months postoperatively and has a multifactorial etiology. So every week, surgeons send cases to us to ask us to evaluate their unstable case. And I tell you, it's like comparing an apple to an orange, to a mango, to a banana. Every single one is different. So we're going to try to make some sense of this. The one question I'm always asked after reverse shoulder arthroplasty instability is closed reduction an option? And really, there is variable success with contemporary implants. In our own series, a contemporary lateralized glenoid implant, a medialized humerus, more than 1,000 cases over the course of 5 years. We had a personal rate of instability of less than 1% in 10 cases, 0.9%, but a surgical revision was required in all 10 of those cases, and hopefully we can help you understand why. Well, why does the reverse dislocate? Dr. Mark Frankel, again, in his group, also has a very large series and helped us try to categorize the reasons that the reverse does dislocate. And we're going to delve into each of these: a loss of compression, a loss of containment, and some type of an impingement. So loss of compression. Loss of compression is the inability of the deltoid to actually function to compress the humeral shaft and the humeral component into the glenoid component. This can be a bone issue because of proximal humeral bone loss. This is a case of mine from almost 15 years ago. As you can see, after an infection, there's a large proximal humeral bone loss. I failed to realize this. I also failed to realize that there was also concomitant glenoid bone loss. So I implanted a prosthesis that was too medial and too superior on the glenoid side, and intraoperatively was unstable. So I attempted to use augments in order to lengthen the humerus. And what I failed to realize is that I was lengthening along the angle of inclination of the actual implant and exacerbating the instability. Similarly, this is another case of ours that I did not recognize the acromion or scapular spine fracture. And again, the deltoid could not compress. This can also be due to a soft tissue issue, deltoid dysfunction. We know about the cuff and the subscapularis. But one thing about loss of compression that is not really spoken about is an undersized implant. Here in Texas, we have very large patients, and this is one of our large patients who has a BMI that exceeds 50. And as you can see, it looks like a nice glenoid implant. It looks like a nice humeral implant. But when the patient adducts his arm next to his torso is so large that it effectively translates his humerus laterally. I failed to realize this, and I should have placed the glenoid more lateral. This is another patient that was sent to us who was unstable. This man was almost 7 feet tall. He was 6 foot 10 inches tall. You see how small the implants are. So there's too much motion of his humeral shaft around the torso, hence leading to loss of compression. Loss of containment. Loss of containment is really a failure of the implant to perform in a semi-constrained fashion. This can be due to a bony issue. One of my patients with an osteopenic glenoid vault, I implanted the glenoid. There was no capability of the implant to contain the shoulder. This can be an implant issue. I'll submit to you that scapular notching is really osteolysis of the polyethylene. And while all of the literature states that scapular notching is not an issue, I firmly believe it is. It causes a mechanical failure and potential polyethylene wear, and therefore a loss of containment. Impingement. By and large, this is the most common reason for instability after reverse shoulder arthroplasty. And the reason can be divided again into bony reasons for impingement, soft tissue reasons, and implant reasons. This is a bony reason, a tuberosity fragment, very common in fracture arthroplasty. If you fail to remove any tuberosity fragments, it can act as a lever, almost like a shoehorn, to lever in between the polyethylene and the glenosphere. Similarly, heterotopic bone can actually form between the humeral shaft and the scapula, especially in revision cases, and can translate the humerus laterally. Soft tissue issues. As we spoke about, these are the patients that I take care of more than twice my own body mass index. And as you see, when you implant an implant, unless you appropriately lateralize the glenoid and bring the humeral shaft vertical to the torso, when the arm adducts, it can be unstable. And finally, component malposition, superiorly tilted base plates, antivariate humeral components, these are all at risk for impingement. So the reverse is unstable because of a loss of compression, a loss of containment, impingement with bone, soft tissue, and implant issues. So how do we handle this? How do we think about this instability? Well, for us, this involves a thorough clinical and radiographic evaluation of the apple, the orange, the mango, the banana. For the humeral side, this involves bilateral scale scanogram x-ray so we can measure humeral length. For the glenoid, this involves three-dimensional reconstruction CT scan so we can evaluate appropriate glenoid position. And for the deltoid, an electromyographic evaluation to determine that the axillary nerve not only functions, but the deltoid muscle actually functions as well. Once we have this information, we place this into a preoperative worksheet. This is something that we developed to objectify the ability to understand these so many different reasons for instability. So we can evaluate the implant type, the implant manufacturer, because not every implant is the same. The glenoid, we can evaluate the position, superior, inferior medialization, and most commonly, the most common reason for failure is an excessive medialization. On the humeral side, we can evaluate a malposition with humeral length compared to the contralateral side and evaluate proximal bone loss. And then we can evaluate the combined nature of this sweet spot, if you will, with the body mass index of the patient. So then how do we solve this? We have all of these ideas of what causes the patient to dislocate. Well, years ago, Pascal Boileau, my mentor, described a retrospective series of patients who were unstable after reverse arthroplasty, and he called it the rule of 15 millimeters, meaning that the greater tuberosity should sit 15 millimeters below the top of the acromion and also 15 millimeters lateral to the acromion. We use that in addition to the amount of proximal bone that's lost, in that if 5 centimeters of proximal bone is lost, the deltoid insertion no longer can function in the nice wrapping compressive effect and therefore can translate laterally. So intraoperatively, if we determine a patient has excessive medialization, if it's less than 15 millimeters, perhaps we can enlarge the sphere to lateralize the glenoid. Again, the purpose is to make the humeral shaft vertical to the torso. If there's greater than 15 millimeters, then you have to put something behind the glenoid base plate, whether that's an augment, for us, a glenoid bone graft, something to bring the glenoid lateral. If there's excessive humeral shortening or proximal bone loss, well, unequivocally, if it's small, perhaps we can use a larger constrained insert. But if it's greater than 15 millimeters and or 5 centimeters of proximal bone loss, you have to restore the vertical length of the humerus and also the deltoid offset. That can be done either with some type of an augmented metaphysis or an allograft prosthetic, alloprosthetic construct. More commonly for us, we see these combined humeral and glenoid bone lesions. The humerus has bone loss. Perhaps it's too small. The deltoid loses its wrapping effect. The glenoid's too medial. And you must be prepared to address all of this, including the soft tissues. So in summary, preoperative planning is absolutely paramount with scaled x-rays, a CT scan evaluation, EMG, worksheet, and you must be prepared to revise everything, the glenoid, the humerus, and the soft tissues. I'd like to thank you again to the Shoulder and Elbow Society and the Coimbatore Shoulder Society, but I'd also like to introduce this to all of our colleagues. In the American Shoulder and Elbow Surgeons Society in the United States, I was the first member of Indian descent. Well, now we have quite a large number, and we have now incorporated the Indian American Shoulder and Elbow Surgeons Society. And we had our first board meeting actually an hour ago. Anand Murthy, Ranjan Gupta, Samir Nagda, who you all know, myself, Paul Sethi, and Anshu Singh are the 6 board members. And our goal with this society is to foster the relations between the Indian American Shoulder and Elbow Surgeons, the Desi surgeons here, and the Shoulder and Elbow Society of India. Our eventual goal is to be able to create an interaction and a dedicated fellowship so that the fellows of SESI from India can come and train with us here. It's all in process, so I just wanted to share with you that this is the beginning, and we look forward to many collaborations in the future.
Thank you, Sumant. That's a great gesture. It's a great thing to do. Collaboration of both societies to advance the academic across the world. I think the world is united in pandemic. Now the world is united in academics.
Absolutely.
Thank you, Sumant.
That was an excellent talk, Sumant. There was a lot of concepts to digest within about 10 minutes, but you actually put it all in a nutshell. I'm sure there are a lot of questions. So if Dr. Desai and Dr. Ram Chidambaram agree, we can go for a short 10-minute question and answer session with Sumant and AD, and then we can proceed with a case discussion. Yes. So is there any questions? Yeah, Dr. Sanjay.
Enjoyed your talk, Sumant. I have 2 questions. First question is that I can understand lateralizing the glenoid, medializing the humeral head with, I presume you have a 135-degree cut of the humerus?
Well, actually, I cut the humerus anatomically, and the construct I use places it at 145 degrees, but roughly as anatomic as possible, yes.
Okay, so I can understand this when you have a lot of cuff tissue still there. What my question is there any indication when you would want to cut at 155 and not lateralize on the glenoid side? Like a massive cuff deficiency with just half of subscap and teres being there. In those kind of situations, would you consider doing the traditional grandma cut?
Actually, Sanjay, I can answer that with our own series. I have not done a traditional Grammon cut in the last now nearly 3,000 reverse implants. And especially in that case that you described with a massive cuff, and what we have now termed here in Dallas, we call this dynamic decentering. If you remember, Ludwig Seebauer described a definition of cuff arthropathy that was very simple. It was centered cuff arthropathy, which was functional, and decentered cuff arthropathy. So in these massive cuffs that are decentered, in order to tension the shoulder, it's actually more important, I believe, to lateralize the glenoid. I cannot tell you that it's as important to perform a 145 or 155 or 135 degree humerus, because as long as the humerus is medialized, meaning that the humeral component is inside the actual bone, I'm not sure that makes as much of a difference as lateralizing the glenoid. But I can unequivocally tell you that if the humeral component is placed on the glenoid, if it's an onlay humeral component, you better be very careful about how much you lateralize the glenoid, and you may consider medializing and moving to more of a Gremon implant, because that patient has a significant capacity for, again, lengthening as we talked about, and potentially even becoming unstable.
Thank you.
And what is the impact of using anatomic reverse in fracture scenario settings?
The same, Ram. You know, we actually, and Eddie is, you know, is just going to present to the American Shoulder and Elbow Surgeon Society our series of more than 80 patients with a proximal humeral fracture done in an anatomic fashion. And Eddie, if you'd like to go ahead and speak about our cementless reverse for fracture.
Yeah, so we utilize the same implant, and there's a slight longer version of the humeral prosthesis, and we use it in a uncemented manner. We can even bone graft around the implant when, you know, to get primary bone stability. And in this series, you know, we have pretty good success rate in terms of functional outcome and pretty reliable 90% healing rate of the tuberosities.
Do you need to, couple of questions, do you need to lateralize here to call it as anatomic? What is the criteria in fracture? Is that lateralization? And second thing is that what do you deal with the greater tuberosity with attachment to supraspinatus? Do you retain it or do you leave it?
Yeah. So in those situations, we don't lateralize the glenoid side, because the glenoid itself is not dysplastic and it's not worn down. So we don't need to excessively lateralize that. On the humeral side, I do think it's really important to retain the tuberosity, or really retain the rotator cuff function. Based on the current literature that we have, when that cuff is gone, you lose too much of the external rotation and stability of the arm in space.
There are a couple of questions. One is about the placement of the base plate. So with this approach, are there any issues with the placement of the base plate, or do you want to place your base plate as inferior as possible, or do you want to keep it in the middle, or how do you go about it?
So I'll answer that. You know, when we performed the original Gremon implant with a peg base plate, that particular medialized design, we always placed the base plate slightly posterior and slightly inferior to the native center of the glenoid. With the current technique that we perform now, effectively, we place the base plate so that the inferior edge is right at the level of the scapula. Therefore, when the glenosphere sits, we have what we call the Mediterranean arch, meaning from the lateral border of the scapula to the edge of the glenosphere, to the medial border of the humerus, it's a smooth line like Shenton's line. Everyone knows we describe the Gothic arch for proximal humeral fractures, but this Mediterranean arch really has been extremely reliable for us to help determine if patients are going to recover internal rotation. There was also a question, someone asked, why do we call it an anatomical reverse as opposed to a bio-RSA, bony increased offset reverse shoulder arthroplasty? Well, the reason is, you know, the term bio-RSA, of course, as you all know, was coined by my mentor, Pascal Boileau, who many of you know has come to India so many times. But we perform this differently from what Pascal does, because we actually do not use a set angled graft. Pascal uses a 7mm graft angled in men and 10 millimeters in women. We actually dial the graft size in per patient. And we perform the operation exactly the same as we would if you were performing a total shoulder arthroplasty with a polyethylene glenoid. We don't detach the supraspinatus. We don't damage the supraspinatus. We're minimal with the subscapularis. And the goal is, even though we're slightly distalizing, the goal is to move the center of rotation as close to the center of the native humeral head as possible, restoring an anatomic center of rotation, which I believe is a functionally different concept than just glenoid lateralization.
Okay, a couple more questions. So when you do a hemi in a young patient, would you go for a modular hemi, and do you see any role for modular hemi so that, you know, ease of conversion later into a reverse? Have we had experience on that
platform?
Yes, and Eddie has also studied that. We do have experience with that, and Eddie, if you'll talk about our component and how we move forward if necessary.
I missed the question there.
So the question is, if a patient has a hemiarthroplasty or requires a hemiarthroplasty, would we use effectively what Karthik was asking, a convertible component?
Yes, I mean we would use a hemiarthroplasty with a convertible component, so that if down the road that the rotator cuff is no longer functional, that we can adjust and switch over to a reverse shoulder arthroplasty if necessary.
I'd like to direct everyone to an article that's it's in publication in the Journal of Shoulder and Elbow Society by Dr. Matson in Seattle this month. And it's on the success rate of total shoulder arthroplasty versus hemiarthroplasty in patients who've had previous surgery, specifically soft tissue surgery. And it's very interesting, as we all know, Dr. Matson in Seattle does not put polyethylene on the glenoid. He does the ream and run procedure. And what Dr. Matson demonstrated is that the patient-reported outcomes and their patient-reported success was higher at 10 years for a hemiarthroplasty with a ream and run than for a total shoulder arthroplasty. And we believe the reason for that is the function of the cuff. More than likely, all of these patients with soft tissue surgeries, instability, cuff, whatnot, have an unstable, not unstable, but a less than normal compression of the cuff. The hemiarthroplasty can tolerate that more so than a total shoulder arthroplasty with edge loading. So I really believe that, Dr. Rockwood, who spoke about hemiarthroplasty, Dr. Matson, I think that they perhaps were far more correct than we give them credit for now, only because the implants they used were not quite anatomic. But if we had truly had an anatomic hemiarthroplasty designed for a diseased shoulder with a concentric joint, it may well be that we may never have to convert that. And for me personally, if I have to convert a patient who's had a failed arthroplasty, I would far rather convert a hemiarthroplasty with an eroded glenoid that has solid glenoid vault than a total shoulder arthroplasty with a cemented polyethylene glenoid with a void and a hole inside there.
Thanks, Sumant. Another quick question. The proponents of lateral humeral offset and the medialized glenoid, they claim that the dislocation rates are very less. In your series with a lateralized glenoid and a medial humerus, what's the dislocation rate, and what is the difference? What is the difference between the two designs?
So to define the question, with a lateralized glenoid, all of the glenoid components that we're talking about are medial to the native center of rotation of the glenoid. But a lateralized glenoid component effectively puts the center of rotation of the sphere at or lateral to the native glenoid surface, as opposed to within the scapula. A medialized humeral component is a component in which the entire humerus implant is actually inside the humerus as opposed to on top of the humerus. So biomechanically, Dr. Mark Frankel demonstrated that a lateralized glenoid and a medialized humerus is the most biomechanically favorable configuration, not only for the cuff, but the combination of the cuff, the deltoid, and stability. Medialized glenoids with lateralized or onlay humeral implants effectively further distalize and over-lateralize, they over-tension the deltoid in our experience. So our experience with instability, Karthik, you ask, in the 2,400, 2,500 cases that we reviewed, the incidence of instability was 10 cases, right? So, 220, it's less than 0.1%. But if you actually medialize the glenoid and lateralize, put that implant on top of the humerus, then you risk over-tensioning not only acromial stress fractures, but it's too tense for the deltoid itself.
Sham has one last question, and then we go to the case presentation. Yes, Sham.
Thanks a lot for the wonderful presentation, Dr. Sumant and Dr. Lowe. Please correct me if I'm wrong. I believe the glenoid base plate is placed by a screwing in type, not an impaction type. So when we are trying to add a bone graft to optimize the lateralization of the glenoid component, as well as to correct the version, when you take a wedge-shaped graft and when you're trying to fix it with the base plate and screwing it in, how do you ensure the correct placement of the thickest part of the graft on the thinnest part of the glenoid? Any technical tips on it?
Magic. No, I'm kidding. So actually what we do is, if you notice, Dr. Lowe demonstrated, and I'll have him talk about this, but we enlarge the center so that we can spin the graft separately from the screw. We actually mark our position. And Dr. Lowe, Eddie, if you'll talk about how we mark that and how we control it, putting the graft down.
So essentially the graft is not fixed onto the base plate firmly.
Right. If you go back and watch the video, you could actually see we pre-ream and kind of enlarge that hole before we put it onto the base plate, and we make sure it spins freely. And when we insert the bone graft, we kind of mark the top, the 12 o'clock position on the bone graft, so that as it's spinning down toward the glenoid vault, you can see where is the 12 o'clock, and that's dialed in based on visual memory, knowing where the worst part of your glenoid wear is. Sometimes as your graft catches onto the glenoid, it may spin a little bit. You can use a separate clamp to kind of hold it down, to hold it in that place as you finish compressing the base plate. So then that would keep it in the spot that you want it to be.
Any incidents of fracture of the graft in your experience?
No, we have not had fracture of the graft, but we're very specific about the thickness of the graft. And in our experience, if you're cutting a wedge-shaped graft, really the thinnest part can be no less than 3 millimeters. Okay. And you have to be careful, obviously, with the quality of the bone, the osteopenia, so on and so forth. And so we try to make sure that, for instance, the smallest graft that I believe you can effectively implant is of a wedge would be 5 millimeters on one side and 3 millimeters on the other side. But we implant that routinely. In fact, I did that 3 times today, and he's going to use that tomorrow, several cases. But we actually have, as he demonstrated, we actually have a box that it's like a miter box. So a miter is something that a carpenter uses in order to cut angles and to shape carpentry. We use the same box, and we create the size we want on one side, the size on the other side, to create a biplanar graft, and then use our reamer for the third plane. So for instance, if a patient has a B2 glenoid, a posterior eroded glenoid, but the predominance of the erosion is posterior superior, say on the clock face, 10 o'clock. So then if we want to place a 6 millimeter graft at 10 o'clock and a 4 millimeter graft inferiorly, but the patient also has a slight superior inclination, we'll create the graft to adjust 6 and 4 millimeters and use the reamer to adjust the inclination so we can work in all 3 planes. There was one question also about the subscapularis. We always repair the subscapularis if at all possible. If we detach it, we repair it.
Okay, thank you very much. Now I request Dr. Sanjay Desai to share his screen and present it to you.
Can you see my screen, Karthik?
Yes, sir. We can see you. Yeah.
So I have one case. This is a 70-year-old general surgeon by profession, male, who had a fall and he fractured his proximal humerus. Those are the X-rays after the fall. So my first question is a very quick answer. What would you do to this fracture? It's a displaced fracture. As you can see in the X-ray lower down, the head is down, the GT, LT are gone. He is a male. He is an active practicing general surgeon.
Sumant?
So for us, this is a reverse total shoulder arthroplasty for fracture.
Okay. So he went to a surgeon and he did a hemi on this patient. Sumant, quickly, 2 or 3 points. Why wouldn't you do a hemi? Suppose I say that this surgeon is 62 years old.
It won't matter to me if the surgeon is 62 years old. In this case, this is a fracture through the surgical neck, a fracture through the greater tuberosity. There's comminution of the tuberosities. The head is posterior invarus. As we can see on the inferior view, it looks as if there's comminution through the lesser tuberosity as well. You know, in this case, all of the literature demonstrates that, even our own literature of hemiarthroplasty for fracture, that the best functional outcomes are really with large tuberosity fragments in patients who have a normal cuff. This man likely at the age of 60 has a 33% chance that his cuff was not normal. At the age of 70, it's 50%. It doesn't matter how active he is. He's got that adaptation that I spoke about of the cuff itself. So we've learned in these cases, the most reliable for us is an anatomic reverse for fracture.
Okay, just for the benefit of the audience, Sumant, let's say this patient is 50 or 48 years old. What would you have done?
So as you talk about 50, 48, 38, 28, you know, it's age, bone quality, fracture pattern, and time from injury to surgery. If the tuberosities are not comminuted and the cuff musculature is normal, well, I have no problem with you either trying to fix it if it's a head preserving fracture, or if it's a head replacing fracture with an anatomic neck component, performing a hemiarthroplasty. And we perform a CT scan on all of our patients preoperatively, so we're able to evaluate if there's fat within the cuff musculature. But if there is fat within the cuff musculature and comminution of the tuberosities, just be careful.
Got it. Thank you. So then he went to another surgeon who revised that hemi, and because the hemi had failed, the tuberosities did not heal, and he had a cuff deficient hemi. So this is operation number 2. He did a reverse shoulder arthroplasty. And you can see the staples still there. So very soon after the operation, perhaps in the recovery room, the surgeon realized that it had dislocated. So Eddie and Suman, both your analysis, your interpretation, and take it. What do we do from here?
Eddie, go ahead.
Well, this looks like a cemented humeral component.
Yes, it is.
With a medialized glenoid component, and clearly on the right side, it's interlaterally dislocated. To me, the biggest part is to notice that the greater tuberosity appears to be missing or absent, and that it does affect the compressive effect of the rotator cuff in stabilizing this fracture. The second part that's hard for me to evaluate is to understand how much of the humerus is still present or missing. So it's hard to judge based on this to say, is the humeral height or length correct? I would probably require more of a full-length scanogram of the humerus to fully evaluate that.
Okay, so Sumant, how much from this X-ray, it looks like the shaft is more or less preserved, the proximal humeral shaft. What is gone is the tuberosities, and we know that because the hemi was revised because the GT had disappeared. So how much of the discrepancy or loss of humeral length would you take as significant?
So it's 5 centimeters is significant, but if the tuberosity is absent, then you have 2 different problems, because not only do you have a loss of humeral length compared to the contralateral side, but you have a loss of the ability of the deltoid to wrap around the tuberosity. So it's 2 different problems. The third problem is that the glenoid component not only is too medial, it's slightly superior. So there's the third potential for posterior medial impingement of the medial portion of the humeral component on the inferior part of the scapula, inferior medial part of the scapula, just under the glenoid itself. So there's a lot of variabilities here in this case.
So how would you take it further? What would you do?
So first things, a scanogram, as we talked about, humeral x-rays. You just get, Sanjay, you're giving my talk. It's fantastic. I love it.
Yeah.
So first thing you do is you do a full preoperative evaluation. Oh, I didn't put my slides up. Sorry. So you have to measure, you have a full scanogram on both sides to measure humeral length. You need a CT scan of the glenoid to determine glenoid component position. You need a deltoid evaluation because we know 2/3 of all patients who have a proximal humeral fracture have a deltoid neuropraxia. So you must evaluate all of these points and put together your worksheet. If the deltoid is functioning, fine. You must also do an aspiration to determine whether or not this patient, maybe this was the recovery room or not, had some subclinical hematoma that was infected. Assuming that's not, you have to evaluate the deltoid, the humerus, and the glenoid. I'll tell you, if you actually make me with this one x-ray, tell you what needs to happen. The glenoid needs to move lateral. Whether that's a larger glenosphere, probably so. The humerus needs to be vertically lengthened, because what the surgeon did, it looks like, is a larger onlay tray, and consequently, when the arm is brought into adduction, it translates laterally. So you need to vertically lengthen this and bring the glenoid out and down.
Okay. So the surgeon opened the joint. Of course, no infection, the nerves are okay, and all that is fine. So he opened it and put a thicker poly. And
it dislocated.
Yes. The thicker poly is not the right solution.
How come you took this case from my archives? This is
I have my sources.
Yeah. You're very sneaky, but now you have another problem. You have heterotopic ossification.
Yes. So now this is on the left is operation number 3.
Yeah.
Now what do we do?
I think Dr. Krishna made this really great slide and this worksheet that we really abide by here. So we kind of have to go back and really reevaluate every one of these points separately. So like he said, there's the loss of containment, the loss of compression, there's the impingement issues leading to the instability. When we look at this first, the glenoid component appears to be a little bit superiorly positioned. So I can kind of see a shadow of the inferior glenoid that the poly may be impinging on. So it doesn't matter how much poly we put into it, it will impinge on the inferior glenoid and lever out. The second thing is the humeral side. The humeral implant, it may still be off in terms of the length. When you increase the poly, you do not get the vertical distance back, but you really get this oblique lateralization. And it really changes the angle that the deltoid pulls at. When you reach anterior internal rotate, the deltoid can often become a distracting force that helps you dislocate the arm. And then the third thing, as you all have mentioned, is the heterotopic ossification. We have seen here an experience where the heterotopic ossification right over that inferior arch or right over that armpit area being another cause of impingement, levering this humeral implant out. So you kind of have to address all of these in an itemized manner, and it probably ends up being a revision of the glenoid and the humeral side, not just really a surface exchange.
Got it. So this is what was done. The heterotopic ossification was impinging and leading to instability and was pushing the humerus up and out. So that was removed and a retainer poly was inserted. So this particular design has a retainer poly, like you have a retainer poly in the hip. And that seems to have done the trick.
Wonderful.
I rest my case. Thank you very much, the
Thank you very
panelists,
much.
for your opinion.
So Sumant, Dr. Sanjay held an excellent webinar last week with Mark Frankel. And so this case was for you, preserved for you for this. So you
Wonderful.
uh,
I think he took that out of my own case file.
okay.
Can I put one?
So we can quickly go for Dr. Ram's case. So quickly go through the case. Sumant has got only 10 minutes
Okay.
left.
Very quick. Are you seeing my screen?
Yes.
Yeah.
Okay. Just a second. Okay, a warm welcome to everyone from Shoulder Elbow Society of India. So, as a case presentation, we go through. So, 43-year-old gentleman suffering from known seizure disorder for 13 years on medication. He sustained an attack of seizure 10 months ago, and he sustained bilateral shoulder fracture dislocation. The history is that he had ORIF, open reduction internal fixation of both shoulders, and he's presenting to me at 10 months post-surgery with a painful right shoulder with limited movements. And that's his range of movement, active abduction, around 60, 70 degrees. He can't do more than that. And that is the amount of rotation. He has internal rotation deformity fixed, no external rotation possible. And that is a clinical scenario. You could see flattening of the anterior shoulder and the bulging of the posterior shoulder is a classical sign of posterior dislocation. These are the X-rays. Comments, it's 10 months post-presentation. Comments, Suman?
So this is effectively a type 2, Boileau type 2 proximal humeral fracture sequelae that has had previous surgery. Yes. So for those of you who don't know, type 1 sequelae, of course, is a collapse of the humeral head. Type 2 is a locked dislocation. Type 3 was described as a surgical neck non-union. Type 4, tuberosity, non-union or malunion. We described a type 5, which is a graded tuberosity non-union. But effectively, this is a locked dislocation, locked posterior dislocation with a failed open reduction or fixation. However, I would submit to you, Ram, we've all been here in this place, yes. And we would call this just an open internal fixation, no reduction, OIF.
Okay. Okay, and I want to go through the previous X-rays the patient had, because this is a question of when did that dislocation happen. So this is the set of X-rays. Go back to that. So that's the dislocated head locked, and you see one screw is dangling against the glenoid, causing damage. Now this is the set of immediate post-op X-ray the surgeon had. AP view. There was no lateral. Comments?
The screw is still in the same place. The head is still in the same place.
Yes.
It hasn't moved. The good news is that the screw has fixed the head posterior to the glenoid, so it doesn't have to move.
So the patient had a 1 month follow-up. This is the set of X-rays. Comments? I didn't cut it. That was the inadequate X-ray.
I think this is important. Eddie, do you want to comment about how important our X-ray views are in the evaluation of patients? Because we have a lot of young surgeons listening. Yeah, I think you're muted there.
Yes, so we do a standardized radiograph for all of the patients, and we do a standard AP, a true AP of the shoulder, and we do a scapular wide view, an axillary view, where we can see the glenoid vault and down the scapula body. And then we also do a full-length humeral X-rays, even the contralateral side, so we can fully evaluate both the shoulder joint and even part of the elbow joint. And we do that routinely for every patient. Absolutely. That way, something like this doesn't happen where we're kind of caught in a tough situation.
I think the key point is to recognize this at the time of surgery. I would recommend even dynamic screening of the shoulder after you've done the fixation to make sure that it is located, and follow-up X-ray. Yes, you should get the absolute glenohumeral joint lateral view. But again, look at this. This patient had a 2 months follow-up, a good AP, and a reasonably good axillary lateral view. Now what? That's a problem. This happened in, we have come across cases like this in the US, Sumant?
Absolutely. We, again, I think you took this from my case file. Exactly this case was sent to us actually last week. The surgeon could not understand why the patient had a resting position of the arm in internal rotation and had no motion.
Yes.
Despite the fact that the head was actually not locked, but was malunited posterior and plated in this position. And I think the point for all surgeons listening that Dr. Ram is making is that if you're going to use an angle stable fixation with a locked plating, you need to make sure it's anatomic before you leave the operating room, because you only have one shot.
Exactly. So I think that's important. Just move on. So it's neglected, and the patient came to me at the 10 months post-operative. This X-ray, as you had seen before, had some glenoid damage because of the screw and the fixed posterior dislocation. Now, what is your plan, Sumant?
So, of course, for us, you know, we go through the evaluation. In this case, laboratory indices, aspiration, so on and so forth, EMG evaluation, assuming all of that is normal.
No clinical signs of laboratory signs of infection. Right. It seems well controlled now.
And then the CT scan, we perform a CT scan evaluation. Of course, I'm sure you have that. We evaluate what the head, the angle of the head, how much of the head is still present based on the near criteria, the articular surface component. So there are many different ways to address this in young people. You know, for us, we actually will take this with what we believe is the most reliable source of treatment, which would be a reverse arthroplasty for fracture. It doesn't matter to me how young or old they are. Yes. But there are some people who would perform a rotational osteotomy of the head, yes, and actually allograft anteriorly into that area to recreate the space. There are others who would perform a hemiarthroplasty. I mean, we see the glenoid deficiency and all of those things. I cannot fault anyone for doing heroic operations. I can just tell you in my hands, and Eddie can probably speak for his, this would be a plate removal and a reverse arthroplasty for fracture.
Is any time duration whether you would go for a reconstruction, stabilization, McLaurin's type? Any time duration?
Yes. Yeah, and the problem is the plate fixation. You know, that's really it. It's not, if there was no plate fixation, this was an isolated lock type 2 sequelae, there are many different options, but the problem is the plate fixation. The plate fixation and the violation that was done by operating this space. And that becomes very difficult to correct without an arthroplasty. Exactly. I'm not saying it's impossible. There's some people who would do all of those things, but 6 is the most durable operation for me. Yes. I'm old, Ram. I only have chance to do one operation. I can't do all these and revise. I can only do one.
So I just listed it because you have seen the CT scan pictures here, as Sumant described, posterior dislocation, glenoid, some changes, and it's very anterior plating. So this is the options. You have to remove the metal work anyway. The option is as listed, leave alone, or stabilization, or McLaurin's, but that's possible if there is no plate. Osteotomy is in rare circumstances. Hemi is almost going out of fashion for this particular fracture scenario, and reverse shoulder is an option as well. So any comments, Eddie?
Yeah, in this case, because of the chronic nature, you know, I'm really worried about that screw really affecting the glenohumeral articulation. I think there's already arthritis kind of settling in because of this. So I would want to replace the joint surface. I think that just removing the plate and relocation may not also address the instability nature of this. You know, the glenohumeral joint is probably also stretched out.
Agree totally. If you recognize early on, it'll be easier to correct, but if you leave it longer, you have problems with the scoring, stiffness, as well as some issues with cold welding of the screws, because we don't want to damage the proximal humerus much, because I have to use the Midas Rex to burr off all the screws and then take it one by one afterwards. So it's quite a lot of time spent in taking the metal work just to. So these are the cold welding screws. This is taken out. Then I did the LT osteotomy. Then we had to go. The longer the biceps was stenotomized, LT osteotomized. Then I spent some time digging out the shoulder, get the femoral head, and that's what I found. So it's malunited and coming as a loose piece, and the cartilage is completely gone. So I think in such scenario, it's better to replace. So I manage the tuberosities. I was speaking to AD before. I like to keep the tuberosities in entire nature. So put tag switches of the GT as well as the LT. Then you look at this glenoid. How much damage already caused by the screw. So I think this takes Suman's point. There is not much good results with the hemi if you do it in this patient. Patient is only 48 years. So you would go to reverse?
Yes.
Yes, sir.
Yeah. So I think I just put the title as anatomic reverse because it's a 145-degree prosthesis. There is no need of lateralization in a fracture scenario, and you're repairing the GT and LT together to retain the shoulder like normal looking. So this is the base plate and the glenosphere, and you got the humeral trauma stem with the liner, and you have the tuberosity repaired side to side, as well as a couple of switches in the transosseous to go vertical. So we're just repairing the post-reverse tuberosities like anatomic hemiarthroplasty repair. So we really have all the rotator cuff stabilizing action. So you would have necessary restoration of regular movement. Is that right, Suman?
I think that's absolutely right. That's a beautiful operation. It looks wonderful, and congratulations on the difficult case.
So, and this operation was done before the national lockdown was announced.
Wonderful.
Oh, I haven't seen the patient. I've just seen once telephonic appointment just to say, oh, move the shoulder with the stick and stuff like that. So that's the post-op X-ray. No other X-ray is done. So I asked my fellow to get the videos, pictures done today morning. So the patient sent. He's happy to show his video.
Fantastic.
And I was asking him whether I can show this in the meeting. It will be live streaming in YouTube. He said, more than very good, doctor. You give me the YouTube link, I will see it.
Well, absolutely, Ram. That's an absolutely wonderful case. And
that's this is much more interesting. So this is showing the left side and the right side, the amount of external rotation and elevation after this reconstruction within 2 months. So with the reverse shoulder, it is possible to leave them alone in a sling, and then I just mobilize them from day one with the assisted arm elevation exercise up to 90 degrees, trying to achieve as much movement as possible at the end of 2 months. So I think the take-home points I put, high index of suspicion for a posterior dislocation. If there is a 4-part, 3-part fracture dislocation posterior, you have to make sure that the glenohumeral joint is located, and you take orthogonal views in every single follow-up, because we do these 2 to 3 cases regularly. And this is my recommendation. After you finish the fixation on the table, do a continuous dynamic screening, because the humeral head is like a cricket ball. So you would be thinking or cheating yourself that the screws are not long, but in reality, it might be long. So do a dynamic screening and then follow up regularly. But if you recognize a dislocation or a screw penetration, act immediately. Don't let the screw long or dig against the glenoid. And of course, the revision is complex. It needs infrastructure, equipment, skills, and a good compliant patient. Any more comments?
Absolutely wonderful. In the interest of time, I just have to say that Eddie and I are going to have to leave the conference. But we want to thank you.
Now,
David,
thank you very much, Suman, for sparing time amidst your very busy schedule you've been operating.
On this occasion, I like to invite everyone for a SESI Best British Elbow Shoulder Society combined meeting on elbow arthroplasty on this Sunday, 4 p.m. And I'm very much eager to look forward to collaboration with American Shoulder Elbow Society of India. Thank you.
Thank you very much. Thank you, Eddie.
Everyone.
Thank you, Sumant.
Thank you, everyone.
Bye-bye. Take care.
you. Bye-bye.
So I think so Sumant and Eddie have left, and I've got a case to present. So I'll quickly present the case, and I'll ask Dr. Sanjay's and Dr. Ram's thing. So let's. Uh, how do I, can I share the screen? So again, this is not a very dramatic case like Dr. Desai's or Dr. Ramchidambaram's. This is a 90-year-old fit and active gentleman. He's so fit and active, washes his own clothes. His main complaint is recurrent hematoma, right shoulder, and inability to lift the shoulder. So that's the X-ray he comes with. He is a fit and active 90-year-old. He and his wife, they live alone. They take care of everything, and physiologically he must be around 75. So, so Dr. Sanjay Desai, Dr. Ram Chidambaram, I think there is. What would you offer to this patient? He's 90, fit and active.
You have an MRI of this, and what is his range of movement? What is his complaint? He has pain?
Recurrent hematoma. At least in a week, once the joint swells up, he's unable to lift the arm. He's only able to bring it up to his. That's the movement he has got. Nothing more than that.
Okay. And these symptoms are since how long?
For the past 6 months.
6 months. So, and he has pain as well?
Yeah, he's got wrist pain. And when the hematoma comes, basically the shoulder is unstable as well. It probably pops in and out, and that's the cause of hematoma. And that's the time he has excruciating pain.
Okay. And he has no history of trauma or any blood disorders?
No, sir, nothing.
Okay. So then you have I would next ask for an MRI.
Okay. So he had an MRI, but I don't have it right now. It's a cuff tear arthropathy, no surprises.
Yes.
No inflammatory pathology.
No inflammatory pathology.
So if he is 90 years old, he has sufficient symptoms that he desires to have some relief of his symptoms and treatment, then reverse shoulder arthroplasty would be my choice.
Okay, sir. Dr. Ram, would you do the same?
Agree.
Okay. Dr. Raghuveer?
Raghuveer, muted.
Okay.
Agree with Karthik.
Okay. So that's what he got. He got a reverse shoulder. Any comments?
So do you do bone mineral density in this case to check for the osteopenia?
Well, in this case, no. If the patient is extremely osteopenic, then we might consider that. But this patient, the bone looks reasonably all right. We don't routinely do that. Do you do a BMT scan in all your reverse patients, Dr.
Reverse shoulder arthroplasty is done in somebody over the osteopenic, osteoporotic age group only. I don't think that routine assessment makes any big difference. If there is a younger patient with a significant pathology, you might need to do.
No, I don't do routinely because I don't think it's going to change my treatment.
So with this,
sorry, go ahead.
No, I wanted a comment on the X-ray. Do you think the component positioning, everything is all right?
It's difficult to say from only one view, but
yeah, I agree.
Critical. I'm a little worried about the inferior screw of your base plate.
Okay.
That is one.
I think we need a true AP to see the glenosphere as a hemicircle, because otherwise you would not be able to identify whether that glenosphere is correctly engaged on the base plate.
Okay.
The second thing I agree, the inferior screw is looking that it's slightly inferior to the glenoid.
I'm not sure if we have another X-ray view, but yeah, there is. I'm not hiding anything like that. This actually is reasonably well fixed glenosphere and good component placement. That's the gentleman at 6 weeks. So at 6 weeks, he's got full elevation. He's got good X rotation. Now we achieved good range. Now the only complaint he had was he's unable to eat rice with his hand. The rice slips away, Now, the wife complains that the old man has become mischievous. He's throwing around the rice everywhere on the table after the surgery. So, we eat the rice with our hands. We want to mix it, And so on examination, he has got weakness of abduction, adduction of the fingers. There's a little bit of an ulnar nerve involvement. So I want to know, have you had any incidents of nerve injuries after a reverse shoulder? Dr. Sanjay Desai?
Yeah, I've had a couple of cases, and if I can blame two possible reasons, often are the cause for this nerve damage. One is intraoperative. If your humeral cut is too less, you're not cut enough of humerus, which is often the case with this evolutus jig, then you might end up struggling reducing this shoulder on table, number one, and you might end up causing some lengthening strain of the C8T1. That's reason number one. So you may have intraoperatively aggressively retracted or stretched. And because of the lengthening itself, also can cause neuropraxia of C8T1. So my main culprit in this case would be not having cut sufficient amount of proximal humerus.
Dr. Ram?
I agree with that. I think the main thing is lengthening. The arm is lengthened automatically in the reverse shoulder. So that will cause some sort of stretching of the brachial plexus. Yes, I had a radial nerve neuropraxia, two cases. Both of them were revision. Basically, there was already had operation 2, 3, and then we go in and do that. Those sort of cases, the nerve flexibility or the scar tissue might be too much. So they had neuropraxia, but both of them recovered. So you need to give time and space. If you are sure that it is not any actual physical damage, you can wait.
Sanjay Desai, in your cases, did you have to intervene, or did you?
Did you have to what?
Intervene before the nerve injury you had, or did you just wait?
I just waited, but in this case, it's how many months? And 6 months, you said?
6 weeks.
6 weeks. So I don't think you have any choice but wait.
But
Karthik,
one thing to notice is that both of the neuropraxia which I had radial nerve, the symptoms were immediate.
Okay.
Post-operative, and then they were there for a while, and then there was 3 to 6 months it disappeared. Why should the symptom appear after 6 months? So that rule out sometime, like the injury, the problem maybe in the cervical spine, just need to rule out. Keep it in mind. May not be due to the shoulder always.
Karthik, Karthik, did you take the full length X-ray for comparison? How much lengthening it happened?
Yeah. I'll come to it. I'll come there. So this is immediate actually. So 6 weeks at by probably 3 weeks is when you start eating with your hand and all that. So they've noticed it only then. He presents 6 weeks. So I just wanted to bring this point to bring out this point of lengthening we cause in the arm. And as rightly pointed out by Dr. Desai, the amount of lengthening and the position of the arm during surgery, we actually place the arm in extreme extension and external rotation while we are preparing our humeral component and the glenoid component. The humerus is retracted posteriorly. So the arm is actually in extreme extension and external rotation. And that's the position where you put a lot of strain on your plexus. So these are studies which have been done. There are a lot of studies, intraoperative neuromonitoring, high incidence of nerve alerts you see while performing reverse shoulder arthroplasty, and limited preoperative range is another risk factor. If the patient has got limited preoperative range, extreme ER exonotation during preparation can put your nerves at risk. So the need for increased glenoid exposure will actually cause prolonged retraction in a difficult case, and that can actually stretch the nerve. So that's the point I wanted to bring out. And again, as Dr. Raghuveer was mentioning, arm lengthening is a very important thing. You need to lengthen the arm. So inevitably you lengthen the arm when you do a reverse. but the lengthening should be around 2 centimeter, not more than that. The risk increases drastically when you lengthen more than 4 centimeter. An increase in length beyond 2 centimeter actually increases the incidence of neurological injuries so much. And this is the instrument used for lengthening the arm in this Alex Ladderman's review. And you can see when you lengthen the arm too much, then there are a lot of problems like acromial stress fracture and neurological lesions, especially with the old Grammont prosthesis, which actually relied on lengthening for stability. Some aggressive lengthening in some patients has led to neurological problems you need to keep in mind. But the newer designs actually do not rely on lengthening, and we don't lengthen the arm too much. In this patient, the weakness completely resolved in 3 months. He was a happy patient. At 6 weeks, he was very happy. The only problem was this transient ulnar nerve weakness. At 3 months, he was completely resolved. His lengthening was about 2 centimeter only. So what I felt was, I put the arm in the sling in elbow inflection after the surgery. And I thought that could be also a contributing factor for lengthening of the for the strain on the ulnar nerve. So after this, I've actually stopped putting our patients on a sling after reverse. So after reverse, they usually the elbow is kept in slight extension. The sling is only for comfort, taken off immediately after surgery. Day 1, they can take the arm and they can use the arm. So maintaining that amount of high elbow flexion with the sling after surgery could also contribute to strain on the ulnar nerve. So that was one thing I learned in this case. So thank you very much. So any comments? Dr. Desai, do you place patients in the sling after surgery?
Yes, I do place them in the sling, and I don't think that contributes to the ulnar nerve stretch that you had in your patient.
Okay, so it's been reported.
I give them a sling, but for comfort, they're allowed to use the arm. Especially in the cuff orthopedy setting, you can leave the arm free as well.
Yeah, it's kept
that may not be the reason for ulnar nerve.
It has been reported in literature that if you keep sometimes we ask the patients to strictly maintain this sort of an elbow flexion. So they say that even that can cause a little bit of a neuropraxia. So we need to keep that in mind. So that's the point I wanted to make. So with that, if there are no more questions, I have to immensely thank Dr. Sanjay Desai, Dr. Ram Chidambaram for having participated and contributed greatly to this meeting. Over to Dr. David.
Thank you very much for the nice discussion. And it's very lively and very, I'm sure, useful to everyone. I think Gopal is also there. Thank you, Gopal, for participating. Thanks, Sanjay. Thanks, Ram.
Thank you.
All the best for your future meetings. Okay,
thank you very much. Thank you, David. And thank you, Karthik. Thank you very much. Enjoy.
Thank you very much, sir. Thank you very much.
Thank you. Bye-bye.
Take care. Take care, David. Bye.
In spite of being such an odd time, we still reached out to 300 people.
Excellent.
300 people on Ortho TV watched it.
So we should thank Dr. Neeraj and his team for actually taking this meeting so smoothly. Thank you very much.
Okay, thank you. Bye-bye, sir.
Okay.